Yeah, we're live now.
Well, welcome everyone to today's meeting of the South East London Integrated Care Partnership, our inaugural meeting, when we'll be agreeing both the role of the partnership and looking at our strategy for South East London. I won't get everyone to introduce themselves at the beginning because we have a lot of members of the board, but what I will ask everyone to do is introduce yourself individually as you come in to speak, saying the organisation you're from. I'm Kieran Williams, I'm leader of Southwark Council and co-chair of the board. The person I will get to introduce themselves now is Richard as the other co-chair. Richard, would you like to introduce yourself?
Hello there, I am Richard Douglas. I'm chair of the Integrated Care Board for South East London and co-chair with Kieran, and we plan to rotate the chairing the meeting.
Thanks, Richard. And we do have some apologies this morning I want to give. So we've got apologies from Councillor Jim Dixon, Cabinet Member from Lambeth, from Norman Lamb, Chair of South London and Maudsley, and from Teresa O'Neill, Leader of Bexley Council as well, although all of those organisations are represented here today by other people. So the first item we've got on the agenda today is to talk through the terms of reference for this group. And I'm going to ask Richard to introduce that in a minute. But throughout the meeting, please do raise your hand if you want to come in, and I will invite you in to speak, to ask your question or speak. And just a reminder to people to turn their phones to silent so you're not interrupted when you do come in. Richard, over to you to talk about the terms of reference.
Thank you very much, Kieran. And as Kieran said, this is the inaugural meeting of the Integrated Care Partnership, and you have in your papers a draft terms of reference for the partnership. Just say a couple of things about that by way of introduction before we get into questions and discussion. So the Integrated Care Partnerships are set up under legislation, but we have quite a degree of flexibility within that legislation as to membership of the Integrated Care Partnership and roles and responsibilities. There are a few givens in there, but there is quite a lot of flexibility. And we've been clear from the start, not just within the Integrated Care Board, but with discussions with other partners, whether they're from our various institutions or our local government leaders, that we really want this Integrated Care Partnership to be something real. There is not a lot of point in getting this number of senior people together if it was just a talking shop. So in the terms of reference, we've tried to approach this by saying, what are the key things that this partnership can do? And within that, what are those things where you could really add value? And we had a long conversation with all our partners about this over the last year to 18 months. You'll see in the papers an earlier discussion document that we produced. But essentially, what we want this partnership to do is to focus largely on three things: on agreeing and then overseeing the strategy, the integrated care strategy for South East London, for providing leadership across a set of programmes within South East London, and then for overseeing some specific areas of performance within South East London. What we don't want it to do is to interfere with what individual organisations themselves do. We've worked on the principle of subsidiarity, so we don't want to take everything up to the level of the Integrated Care Partnership, but we do want to make sure that it really does add value, and that's what we try to reflect in the terms of reference. And the final thing I'd want to say on this is, within that terms of reference as well, we want to quite clearly establish the relationship between the Integrated Care Partnership, the Integrated Care Board, and other partners in the system. What we don't want to have is a situation where the Integrated Care Partnership will set a broad strategy, and then people feel that the Integrated Care Board or other partners go off and do something else, where there's a different room in which people have a conversation about things like money. So we've tried to establish that very clear oversight link between the Integrated Care Partnership and the Integrated Care Board. We may not have got all of this right at this stage, but we'd welcome the chance now to discuss it with you and take any suggestions for change or amendment. You're on mute, Kieran, I'm afraid.
Oh, thank you very much, Richard. As people wait to bring in with their questions and amendments on this item, I think obviously important to say we are here with the purpose of improving the health and well-being of the residents that live across South East London. We know that this is a system that perhaps is not the perfect way to organise things, and that has some ambiguity about exactly how it's expected to be arranged, and we're having to work through that and make it work for our patch. But certainly what I've welcomed personally through this process is the commitment from Richard and from Andrew in the ICS as leads to work with all of us to design how we're going to work together. And I certainly welcome this paper as something that I recognise from the conversations that as Southwark we've had with you over the last few years. I hope people in their comments will be able to say the same, and they feel that this is a real evolution on the conversations you've had. So if people want to indicate if they would like to speak, please do. But Ben, I think we had one suggested amendment to the terms and conditions that had come through from conversations with Lambeth in particular, but certainly ones that I think are important, having seen them myself as well.
That's right. Councillor Dixon can't be here today, but he asked me to explain two concerns that he had regarding the terms of reference. First of all, in section 48 of the terms of reference, give the partnership a responsibility to make an annual assessment of progress against strategic priorities. And Councillor Dixon suggested that the board should be obliged to make a response to the partnership's annual assessment to make this a useful power. And secondly, in section 410, the partnership has the ability to ask the board to review its approach where the partnership is concerned about progress. But this role is limited to some specific areas in the current drafting. It's limited to the specific areas where the board and the partnership have agreed that the partnership should have an active role in overseeing system performance. And Councillor Dixon argued that the partnership has a legitimate interest in many aspects of the performance of the system that go beyond its specific oversight role on particular issues. So he asked for the partnership to be able to raise any range of any performance issues that it's really concerned about.
Thank you, Ben. So two recommendations to us there that I'm just going to ask people to think about. I shall come back to those. There's a couple of questions that people want to raise. So please do have a think. They seem very practical and sensible things to me. Clearly, we have a leadership role together about delivering integrated care across the piece. But if we were all worried that, if for one example, trust within the hospital system, we're really going to struggle to work this winter, and indeed many of us will be worried about that, not least those who are running those hospitals. I know I think we'd all want to have reassurance at this level that we're working together to find the best support we can to overcome those challenges. But let me bring in the two questions. So I've got Foloke, if you would like to come in first, and do turn your camera on and introduce yourself.
Hello everyone, good afternoon. My name is Folake Shedmo and I'm the Director South East London Health Watch. And of course, as you know, Health Watch is a system partner and the independent voice for people who use health and social care. And I think it would be good for the terms of reference to reference that in 2.1 and in 4.11. We talk about the system partners are named, but Health Watch is omitted in both of those. Thank you.
Point very well made. So we'll collect up these amendments and come back to them before we agree them finally. Jill, if you'd like to turn your camera on and introduce yourself.
Hello everybody, I'm Jill Lockett. I'm the Managing Director here at King's Health Partners. I was just thoughtful about the relationship between the ICP and the ICB and whether the terms of reference go far enough to understand how the ICB and ICP will talk to each other and what we do if there is difficulty, whether that's about progress or challenge, and how we will have that conversation. I thought the terms of reference didn't quite go far enough, Kieran.
Thanks, Jill. I think we're all trying to work through exactly that amongst other things. So a really good, well put question. John T, I see you want to come back on some of those responses. So John T and Ben, between you, if you'd like to come back on all of those suggestions.
Thanks,
and do
thanks.
Introduce yourself as well, John T.
Thanks, Chair. Yes, of course. Hi, I'm John T. Heversich. I am the Joint Medical Director for the Integrated Care Board. And I suppose we've been giving some thought, particularly to Councillor Dixon's proposals prior to the meeting. So I just wanted to share some thoughts on possible amendments. I would also personally certainly support the inclusion of Healthwatch, which has been described, and I think we just need to give some thought to Jill's proposal around how we might want to strengthen the description of the relationship between the ICP and the ICB, and I do think that's something that will be ongoing and we'll almost certainly need to iterate, but welcome others' thoughts. In terms of Councillor Dixon's suggestions, I would suggest that we might change clause 4.8 to the partnership should provide its assessment of progress against these key priorities on an annual basis, possibly as part of its revised integrated care strategy. The Integrated Care Board and other organisations represented on the Integrated Care Partnership, where appropriate, should set out how they plan to respond to the issues raised in the partnership's assessment. So it's just trying to pick up that particular aspect. And then on for clause 4.10, I think again picking up Councillor Dixon's comments, in relation to its oversight role, the partnership will be able to ask the Integrated Care Board and other organisations represented on the Integrated Care Partnership, where appropriate, to review their approach to key areas, for example, those identified under section 4.6, where there is evidence that the system is failing to deliver its strategic intentions to the agreed timescales. So hopefully that will pick up both of Councillor Dixon's comments. Thank you, Chair. I think you're
microphone again. So practical suggestions there. So I think I just want to check with people going through those. So firstly, there is including the references to Healthwatch at 2.1 and 4.1 as the two key parts. As a key partner in the system. I think that seems very straightforward, and my suggestion is that we agree that, but let's come to these back collectively. And then John T's outlined 3 changes to the terms of reference there. So one saying that there will be a progress report back to us against the actions that agreed. One saying that the plans of the board that the partnership is able to ask the board to respond directly to its recommendations, and the board will respond directly to the recommendations of our recommendations from this partnership. And the final one is for us to be clear in the terms of reference that where we are concerned that plans don't meet the things that we have agreed here are important as a partnership, we can ask either the Integrated Care Board or indeed individual organisations around this table to review their plans and come back to us and say how they will respond where we think there's a mismatch between the needs of South East London and the plans that have been agreed. So they're the four changes. Are people comfortable with those changes? And then I do want to come back also just to the specific question of, do we need to say something more about the relationship between the Integrated Care Board, so that's the legal entity that's responsible for care in South East London, versus this partnership, which is our oversight role of setting the direction as partners from across our patch of South East London. But on the first point, can I ask just questions on agreeing those 4 recommendations? Colin, I can see you want to come in, and please do introduce yourself.
Thank you very much. Colin Smith, leader of Bromley Council. No issue with 3 of those. I do, as everybody knows, have a profound issue with the partnership being over-empowered to direct the local boards. So I personally would record some concern over that one and wouldn't be minded to support it, but no problem with the other 3.
Thank you, Colin. Can I just to tease that out a little bit? So you mean specifically having power to direct the borough-based boards?
Absolutely, yes, indeed. Okay. Thanks, Kieran.
So if we were to have something that is about saying that the partnership has ability to set requests out to the South East London board, number 1, or to organisations that are operating across South East London, number 2? Is that something that you are comfortable with? And I think what's lying underneath that suggestion from Councillor Dixon is being able to ask the big trusts that in our area how they're responding to the recommendations we're making from our meetings here, rather than trying to seize power up from boroughs where we've agreed a principle that things that are best done at a borough level should be done at a borough level. But welcome your comments on that, Colin, and others.
Thank you, Kieran.
Yep. Jonty, did you want to come back in again, and or Ben?
I think, Ben, you were going to come back in with some suggestions on Jill's point. I mean, I think, so Kieran, Chair, based on your recommendation, I think we could certainly look to adjust that point, picking up Colin's point, just to be a little bit more explicit, if that's going to be helpful, around that expectation, because I can understand that there might be room for some misunderstanding there. So I'm happy to draft that in a way that captures that recent conversation.
And Ben, would you like to come back on the point about the respective roles of us as a partnership and the statutory board in South East London? Is there more we need to say to clarify that point?
Well, Jill was suggesting that we clarify how the ICB and the partnership will talk to each other, and I'm conscious that the terms of reference are very much about the formal levers of the partnership to engage with the board and the formal requests from the board to the partnership. But of course, in practice, as we know from our work on the strategy so far, it's a very close working relationship. So perhaps we simply need to include something in the terms of reference to say that the board and the partnership are going to maintain a very close dialogue on the 3 main roles that the partnership has within our system, and that will give Jill confidence that that we'll have the time to meet and to maintain a good relationship.
Thank you. Well, I think that's a really helpful conversation. Thank you very much for the suggestions and comments on how we get to the terms of reference. I think if the best thing to do here is if we could make those amendments, if we could circulate the updated terms of reference to all members of the partnership, and we can formally agree them at our next meeting. But I think we're clear that what it is we're working to in the meantime, from the principles we've agreed just there. Hopefully everyone's happy with that approach. Please raise your hand if you're not, and if not, I shall take us on to the next item, which is the State of the Nation report. And Andrew, did you want to introduce this one first?
Chair, very happy to. I'm conscious this paper was issued for the September meeting, so it's been out there for a while, and in that meeting we had slightly longer to discuss it. So at the moment, I was going to hand to Toby, who may have some reflections from his role as the Joint Medical Director for the ICB and clearly a leader across the system. I just wanted to make sure that the context for this was set. It's intended, well, it may tell people entirely new things. I suspect some new things and some very well known things. So to provoke, yes, discussion and ambition, but set the backdrop for what we're about to discuss as the first thing. Secondly, as an apology, although perhaps it's a promise as well, it is very clearly a partial view of things. We do not have the richness of a full partnership described in the State of the Nation, is the second thing I wanted to say. And thirdly, it doesn't describe a whole set of things that will resolve around this table, but it does set the context for the challenges in which the things we are trying to do sit. I did want to hand to Toby, just for brevity, I did just want to make a couple of points, if it's okay, in relation to the paper rather than present it. A brief paper and a rather long appendix for people to sort of use as a reference document. I thought 2.1, sorry to call that specifics, was pertinent because it picks out premature death associated with socioeconomic factors. And really, for me, as an NHS professional for the last sort of two decades, really to get into a discussion that is beyond the health service is kind of the point. So we're absolutely including these sort of points of reference for a reason, and that then of course points to longer term view and solutions that aren't born out of an annual planning round. So that was the first point or reflection from me. The second one happens to be in section 3.4. We talk as colleagues about the challenge of the finances enormously. I just to be clear, I think in those sections, we're trying to pick out 2 or 3 things that, as well as them being difficult, we do over the next 2 years particularly have policy changes, particularly on the NHS side of things, and colleagues will update me on the local government side, that arguably make the next 2 years decidedly more challenging as we see a removal of some temporary support we had for COVID. And I think that's true of a lot of the public sector. It's certainly true for us. And we have a particular change in national policy on specialised commissioning, which you'll see in the pack makes up a huge amount of the income to our providers into South East London, a bit of a unique feature for us. And I can apologise for it, but I think it's true of most NHS organisations. We have some non-recurrent solutions in play at the moment. So when you stack those things up, the financial challenge feels difficult and is particularly seen in those contexts. And final piece from me, and I don't think it's an entirely personal view. Even if I was awash with money, I don't have the trained people to spend it on. So it implies a reimagination of workforce, which I think is littered throughout a lot of the challenges that we see in the paper. If it's okay, Chair, I was going to hand straight to Toby, who will have predictably some different but I think useful reflections on the paper, and then I'll hand back to you, Chair.
Thank you, Andrew. And Toby, if you'd like to introduce yourself.
Hi, I'm Toby Garrig. I'm the Joint Medical Director of the ICB with Jonty, and also a rheumatology consultant at Guy's and St Thomas's. What I thought I'd do, that there is, in the paper, there is some data around our population health, and I thought I'd just pick out a few headlines from that, just to try and illustrate the challenges which we're facing. And I know that many on the call will be very familiar with these. We know that we have high levels of deprivation within our communities, and this correlates with poorer health and health outcomes, but also with poorer access to care and a greater incidence of risk factors for poor health. We have high rates of preventable mortality, in large part due to potentially modifiable risk factors, and life expectancy we know is lower in our more deprived populations. There's significant variation in life expectancy across boroughs between areas of high and lower deprivation, also significant variation up to 13 years in one borough of what we would define as healthy life expectancy. We have higher than average smoking prevalence than average in many of our boroughs, and we have higher than average alcohol-related admissions. We know that late-stage cancer diagnosis increases the deprivation, which we do see in some of our boroughs again, and that 1 in 5 year survival in those groups is lower. And we also know that cancer screening uptake is lower across the board than the UK average, and that specifically is around bowel, breast and cervical cancer screening. And it's worth stressing that 50% of cancer deaths are potentially due to modified risk factors, particularly smoking, alcohol and obesity. Hypertension case identification and screening is a major challenge. This affects around 30% of offenders in UK adults, and we know that nationally and locally there are only around 50% of these cases have been identified, and of those only 50% are well controlled. So the total market, only around 25% of cases of hypertension are well controlled. This is clearly a very significant driver of long-term morbidity and mortality. We have higher than average prevalence of mental health disorders. Anxiety and depression are two of the most prevalent long-term conditions in our communities, and not only as being significant challenges in themselves, we know that these have very significant impacts on outcomes in pretty much any long-term condition which we see in primary or secondary care. UK maternal mortality is 4 times higher than the UK average in black women than for white women, and 60% of our maternity patients in our ICS are from black background, with significantly higher rates of stillbirth in those communities as well. We also know that diabetes is overrepresented in the more deprived populations, and there's significantly high levels of excess weight and obesity in our children, and again, this disproportionately affects our more deprived and marginalised communities. And finally, as we all know, we have lower than average levels of vaccine uptake, and this particularly highlighted the challenges of the lack of trust from some of our communities during the pandemic. However, what this does, to me, present some fantastic opportunities. We have a really great chance to build a learning and resilient health system, and focusing on prevention to keep our people healthy for longer, and ensuring when they do get sick, they get seamless joined up care which is close to home, and they're not disadvantaged by background. And we're typically looking for support in addressing the complex drivers of poor health and building communities which support people to look after the health and well-being of themselves and others. So my personal reflection is, I think there's obviously lots of priorities we could talk about. I think for me there are maybe 3 which I'd draw out. One is understanding and addressing the frictions at the interfaces between all the components of healthcare and beyond. This would be between primary, secondary care, between both those in mental health, social care, and also broader public services. And what I've learned as the medical director is extraordinary resource we have in our communities and charitable organisations in the third sector, which presents us with unique opportunities to really bring ourselves together, to blend all these components together to build a really fantastic system for our citizens, our communities, and in particular making sure that every contact counts, that every opportunity we take to address your health and well-being, whatever that might be, is maximised. I think the second is to really understand what the unmet needs are. And I mentioned trust, and we know that for many of our communities, we're not providing what we might be. We're perhaps over-reliance on the health model and delivery from the NHS. So understanding from our communities and from the partnership what the unmet needs are, what is important to our communities, and how we design services which is appropriate to their needs, to be feel accessible and they have faith in. And ultimately using this partnership to leverage from what we would like to see as a transformation approach to service delivery. And the final thing, and this is kind of a challenge to the partnership, is how do we hold ourselves to account? For me, this is around the outcomes, and this is the health outcomes that matter most to our citizens and to our patients. A lot of what we measure is around process, which is absolutely right, but it's really important when we do anything new, we try and improve anything, we reflect on what we're doing, we should be asking, why are we doing that thing? How does this make the lives, the health and the well-being of our citizens and our patients better? And that's the question we should always be asking ourselves, and that is how I think we should be held to account. I'm going to stop there.
Thank you, Toby, and thank you to the team for putting together this paper. I think it's a really insightful overview of the health situation of our residents and the challenges we face. There's obviously some good news and stories in here on the progress we've made, but as you've set out, Andrew and Toby, some real challenges, not least the difference in health outcomes between different parts of our communities across South East London, within our boroughs, between different parts of our community, including, for example, the worse outcomes for many parts of our Black, Asian, ethnic and minority community. Have people got questions on this profile? I think it's obviously really important that we as a partnership start from the needs of our population, but I'd welcome any questions or comments that people have on this at this point. I guess the one thing that certainly stood out to me on page 29 of the profile itself, setting out that whilst in South East London we have a higher than average levels of mental ill health, we have a lower than average investment in mental health services, and that certainly feels like something that we as a partnership need to look long and hard at. And then the subsequent follow-up point it makes in here that a very large proportion of the physical health gap is for those people who have serious mental health conditions, 10 to 15-year gap in their life expectancy as well. So addressing mental health in South East London is crucial, but it's also crucial for addressing physical health as well. At this point, I don't see any hands or questions in the chat. So unless I'm missing anyone, let's say thank you very much for that work. I know much more of this also happens at a borough level, but as I say, really important to be starting from the health outcomes for our residents. So in that case, let's take us on to the main item for today's discussion, which is the development of our integrated care strategy. So this is the main defining document that allows us to think about how are we working together across South East London to provide quality care that's going to be the most impactful it can be on improving outcomes for our residents. And just to follow up on Andrew and Toby's points on this, I think we should all be keeping in mind that we have fantastic opportunities here, having world-leading institutions in our hospitals, in our universities, incredible strength within our communities, in our voluntary sector and our local authorities, and that this is about work that's about health, it's about care, and it's about helping people stay healthy, as well as about getting health support and care to them when they need it most. Jonty, I think you're introducing this one, are you? So I shall hand over to you.
I am, thank you, Chair. So I have introduced myself, but just a reminder, I'm Jonty. I work with Toby as the Joint Medical Director for the Integrated Care Board. And actually, I think that the presentation that Andrew and Toby have just given is a perfect introduction in many ways into this, because if we cannot see reflected in our strategy some of those needs that we've just heard about, and Kieran, thank you for flagging the importance of mental health. If we can't see that reflected in this, then we clearly haven't captured what we need to as a system. So I hope very much, as I just speak to some of the process that we've been undertaking and where we're getting to in terms of our strategic priorities, that you will see that we have worked very, very hard to try to understand what our population in South East London needs and how we would reflect that in strategic priorities for the system and for this partnership board. So I am just going to talk through a little bit of the process and then where we have got to, and we've got some questions for the board, inevitably, because this is going to be, as Kieran has said, a really key part of the work that we do if we link this back to the previous item on terms of reference. I guess nobody hopefully will be surprised that there is an expectation that has been set that we develop a strategy as a partnership, as an integrated care system, and that will sit alongside an NHS system plan that we will also need to develop before the end of this financial year, and that will describe our response as a system to a very, very wide range of service requirements for our population. The strategy, which we're going to focus on at this point, is something that I think we want to feel slightly different. So it won't be defined in terms of a kind of national planning process. It is something that very much should feel unique to South East London and very much reflect this partnership and our population. So what I'm going to be speaking to is the approach that we've taken to try to develop that very unique and specific strategy for South East London. But I didn't want to go further without recognising that it will sit alongside a lot of other commitments that we will need to make in relation to our national obligations to our regulator, certainly in the NHS. So the next slide then just outlines a little bit about the process that we have been through and maybe why we have heard that this needs to look and feel quite different going forwards. And I guess from my point of view, the key things to draw out of this are that at almost every turn, people have told us that they want us to be as bold as possible in South East London. They want us to identify opportunities through which we could make a really meaningful difference to demonstrate improvements in care and outcomes for our population. So they want this to feel bold. They want it to drive a different way of working. So in the change that we've now made, moving from purchaser provider arrangements within our systems towards a partnership approach, how is the strategy going to drive a very different way of working together? And they want us to ensure that it is inspiring, that it's something that connects with people who live and work in South East London in a way that perhaps we haven't before. So the challenge has very much been, how do we create something that feels bold, that feels different, that feels inspiring? And I think importantly, in the conversations that we've been having, it has to add value. So the intention here in working as a partnership across South East London isn't to try to replicate the work that's happening in individual provider organisations or individual places. It's very much about how we create something that makes us, that enables us to be more than the sum of our parts. So how can we essentially find a strategic approach that helps us to amplify the effect and the effectiveness of our ambition, or to identify where there is real advantage in working in a shared way across South East London? So the next slide really just outlines the fact that inevitably, because we want this to feel as though it has a real South East London flavour and feel very owned by this partnership and local people, we've already undertaken quite extensive engagement, and many of you have contributed to that, and I wanted to thank you and thank all of the local residents. We heard from more people last night across South East London who have been talking to us about what feels important to them and what they would like to see in this strategy. The engagement hasn't finished, but I just wanted to recognise that there has been an awful lot so far to get us to where we are. The next slide then is really just to capture what we have heard in terms of the vision that we would want to set ourselves. I'm going to talk a bit about the key strategic priorities in a moment, but we have also been engaging on the vision that we would like to establish for the system. This feels really key because for a system to really empower those people working and living within it, I think we need to be really clear about the kind of characteristics of care that we're trying to deliver. That will mean that people on the ground can feel as though they have the agency and the autonomy to really push forward on improving care for local people in a way that aligns with that vision. And what we've heard, and there's pretty strong agreement around these key characteristics, and I'm not going to go through all of them, but is that essentially we want to think about how we promote health and well-being, prevention and staying well, as much as we do emphasise illness. We want to think about how we ensure care is accessible. We want to think about how we bring our services together in a way that supports often quite complex needs in a much more holistic way for people living in South East London. We want to ensure that the services we deliver are equitable and accessible to all of our communities. And we know, particularly through the pandemic, we've recognised that there have been significant parts of our community disadvantaged by the way we've delivered care. We want to ensure that we do this consistently in partnership with those people who experience care and local people and communities. And we want to ensure that through this process, we empower staff working across the NHS and social care and the voluntary and community sector across South East London. So those are the key tenets of the vision, and we'll come back just to get people's thoughts on that at the end. The next slide I wanted to flag is really just outlining the process that I have already talked about, but it has been a process of really engaging in trying to sort of shortlist the priorities that we think we can work best at together across South East London. The next slide flags one component of this that I just wanted to make sure we acknowledged, and that is that quite early on in this process, we did an awful lot of research and engagement to, if you like, understand what was already happening across individual provider organisations and our local places. So we've tried to look at JSNA's health and wellbeing strategies to really understand what the priorities are in each of our boroughs in South East London, as well as looking at the strategies for individual provider organisations, so that we ensure, again, that we're not trying to duplicate or replicate, but we're trying to see where there is significant I guess, synchronicity between those so that we can try to amplify the effect that we have. So that was an important initial part of this work early in the summer. Subsequently, we developed a long list of proposed priority areas, and gradually through processes of engagement and feedback, we have narrowed that down. And I know many of you have had conversations with us either on a one-to-one basis or within local engagement forums recently, so that we can start to narrow that down to the final 5 that I will come on to in just one moment. So the next slide then, again, is really reinforcing the points that I've made, that at every point we have tried to test those priority areas against some key criteria. One being the significance of the impact that we can make, so the size of the opportunity. The other being through the requirement for collaboration. We don't want to do things that don't benefit from collaboration. And the other is around feasibility. So how soon could we make a difference if we work differently on this together, as well as thinking about how we create that strategic coherence across different organisations and places. So those criteria we set out very early on, and we've consistently tried to look at the priorities that have come up in the engagement processes against those criteria. So the next slide then is really about, and this is something we'll come to at the end again, which I value feedback from the partnership board on, which is what it means to be a strategic priority. There are some things which I hope, given the conversations we've had about the terms of reference for this group, that are relatively obvious. Hopefully these will become key priority areas that this board will want to oversee and will take a keen and strong interest in. But actually, we also anticipate there will probably need to be some additional resource allocated to support some of these cross-cutting system changes that we're going to talk about. And some of these will need to be delivered through individual partners taking some responsibility. But I think we'd like to explore a little bit more with this group. What does it mean for us to commit to these priorities that we're going to identify in the strategy going forward? So finally then, almost finally, the moment that you have been waiting for, where we have got to in terms of our initial cross-system strategic priorities through the engagement process. And there are 5 key areas that we have identified through the process of engagement that we've had. Again, many of you will be familiar with these, but it won't surprise you to see that prevention and wellbeing is one of those, and how we get better at preventing ill health and helping people to live healthy lives. There are 2 that relate to children and young people, and I think that very much reflects the feedback that we have had. One, around how we ensure that we give children and young people the best possible start in life, and the other that specifically addresses how we ensure that children and young people, there's a typo in this, but that it's specifically related to how we offer early intervention around common mental health challenges. There's a typo there just on the 3rd one down, but it is a children and young people, but specifically relates to mental health outcomes. And then again, I think relating, Kieran, to your point earlier, there's been strong feedback about the importance of ensuring that adults across South East London can access effective support for maintaining mental health and wellbeing as a key priority. And finally, we have consistently heard again about the importance of ensuring that people can access well-coordinated care outside of the hospital setting that brings together neighbourhood teams that can support people with some of the most complex needs that we have in our communities and with long-term conditions, ensuring that people can access both the care they need when they need it, but also the ongoing continuity and support that they would need from multidisciplinary teams in the community. So that's where we have ended up in terms of the 5 key areas. I just wanted to talk very briefly about where next, but obviously we'll come back to this group in a moment for feedback and comment. So the next slide then identifies that as we have had conversations inevitably about these key priority areas, there are some clear cross-cutting themes that come out that essentially relate to all of them. So addressing inequalities, for example, is something that we would be wanting to do through each of those 5 strategic priorities. Equally, thinking about how we support people transition across different care services in a much more seamless way is a theme that emerges throughout all of the conversations we've been having around our priorities. So what we'll do in the strategy is to draw out those themes that we think are cross-cutting. We will also try to ensure that we draw out what this will require in terms of a different way of working and the kind of capabilities that we'll need to develop in our system to support this change, and also those things that will enable that. So we've had a lot of feedback about the fact that very often people don't have access to patients' records, depending on what service they're in, and what a difference it would make if people didn't have to tell their story multiple times. So there's something there about digital as a key enabler that we need to be thinking about as well. So the next slide really then is to outline the next steps. And in terms of the steps going forward, we're going to continue obviously to refine the vision, and part of the continued engagement is the conversation we're having with all of you as the partnership board today. Increasingly, we're going to work with expert groups to start to be a little bit clearer about where the opportunities are to really make a difference in relation to those 5 priority areas that I've identified. And importantly, how we will know we've made a difference. What are the outcomes we can expect to see? How we know that we've really managed to shift the dial on some of this. So very much in the new year, we hope to be able to share not just what our key priorities are, but how we're going to deliver those on behalf of the partnership for South East London. There are then a couple of specific questions. Obviously, very happy to take any comments or questions, Chair. There are some specific questions that we hope people would consider. The first being around the draft vision and whether that describes the kind of system and care provision that we would be aiming for in the future. The second is around whether members agree with the proposals, focusing on those initial 5 cross-cutting areas for action that I've identified. And then the final one is the point that I made about what it means to be a strategic priority, some thoughts from people about what that would involve. Sorry to have romped through that at such pace, but I hope I've covered it helpfully.
Thank you, Jonty. I think that was very helpful, very clear. And before we get into the conversation, I want to say thank you for the work that's happened with partners across this partnership, including representatives from all boroughs, to work through to get to these recommendations. So I've got a few people asking to make comments, so I shall go through them as people raise their hands. And sorry, just to say to everyone that the raise your hand function isn't necessarily working today. So if you want to speak and you can't raise your hand, please do put a comment in the chat to let me know. Paul, would you like to introduce yourself and ask your question or make your comment?
Sure. Can you hear me okay? Because I'm on new headphones. Great. So my name is Paul Bell. I'm Cabinet Member for Health and Adult Social Care in the London Borough of Lewisham. First of all, I just want to say that I welcome the strategy and all the work that's been put into this. I think we do have one of the best ICSs in the country. So I think we do need to validate all the work that you're doing on that. And it is quite encouraging what is happening. My comments relate to the whole life pathway. So I'm seeing a certain number of themes that are being drawn out, which is good. I don't disagree with them, but how in a narrative and also a procedural model, obviously that comes next, can we demonstrate to our residents that this ICS for South East London has a whole life pathway when you need care, whether it be primary or acute? Because obviously we're struggling with GP appointments. That's the common thing at the moment. But actually the issue is acute care when you need it, primary care, which is an ongoing relationship you have throughout your entire whole life pathway. And then there's the intermediate part, which when I was growing up, it would be community hospitals. So it's kind of, you go into hospital when you need it, and you may not be fit to be discharged to go home. But then there's an intermediary bit that you no longer need to be in acute. So what provision do we have for that intermediate stage before you're fit to go home? So that's just testing out the strategy in terms of how it relates to that whole life pathway, with the example of between hospital, emergency or acute, and being at home, the intermediate part of that, without with the local authorities in partnership. But how is that tested, if at all, in this strategy? Thank you.
Thanks, Paul. Really well made suggestion. I will take all of the comments, Jonty, and then come back to you. I hope you'll be able to keep track of them as we go through. I suspect there'll be some crossover between the things people want to say. So I've got next David. And again, please do introduce yourself.
Good afternoon, colleagues. I'm David Quirk Thornton. I'm the Strategic Director for Children and Adults at Southwark, and I'm here as the Lead Director of Adult Social Services for colleagues across South East London. I wanted to make a couple of comments, if I may. So firstly, to welcome the strategy. I can see a tremendous amount of work has gone into it across the piece, and the priorities resonate with what we see locally in not just in Southwark, but in social care right across the piece. And it was to build on that point, really, that it's not that social care is missing from the strategy, it's not excluded from the strategy, but it's not always explicit. And that's not a criticism, you know, we take responsibility for that too. So it was just to say out loud that if this strategy is agreed, wherever it says care, please read health and social care in the fullest sense, because we will read it that way in terms of the action plans, the health and care plans that will follow in each of the boroughs over the coming months. And in some areas, clearly the focus is on primary care or secondary care. That's absolutely fine. And I hope that future strategies will be able to contribute more fully from a social care perspective as well. And it goes back to the earlier point from Toby, where he was talking about how we're held to account as a system. And it's really important that by design, all parts of the system are held to account in there. So I'm kind of stepping forward from a social care perspective to say we'd like to be more explicit in future strategies. But for now, having had a close read and in conversation with colleagues, we think it's not terribly explicit, but we're certainly reading it as that wherever it says care, we're talking about our whole system, and we really welcome that opportunity for deeper integration. And so yeah, so something for the future in terms of our strategies when we have more time to work together on that and to design in the social care outcomes. But yeah, very happy to support it on that kind of understanding that we're in the game and want to play our full part. Thank you.
Thank you, David. And I think it probably is worth in the final version just pulling out the phrase social care more often, because there is a long history nationally of social care, of course, being underlooked and overlooked. And I know work here in South East London has been very clear about the centre stage of social care and integrated care, and it's worth just making sure that that message goes out to people. So next I had Jill.
Thank you, Chair. So thanks, John T. I think the live course and the major themes come across really well, and there's a lot to support in that. I think some of the principles of how we're going to work together and the principles about value-based healthcare, and that's the breadth of value across outcomes and experience, aren't coming out enough. When we all met in the summer at the Oval, there was a lot of conversation about outcomes and experience for citizens, for patients, their families, and I just don't feel that that feedback is yet coming through the document. And I think there's an element of the document that focuses on process and access, and I understand that in the NHS at the moment, but I think we should try to aim to set out the story of our outcomes and experience that we aspire to for citizens and their families a bit more strongly. Thanks, Chair.
Thank you, Jill. Gavin.
Hi, thank you, Chair. I'm a GP partner across South East London.
Oh, Gavin, you're very quiet. Actually, I don't know.
Can you hear me better now?
That's definitely better, yes. If you want to introduce yourself, yeah.
I'll just introduce myself. I'm Dr. McCall, GP partner in South East London, also a PCN clinical director, and here is the primary care representative from this board. John, you know you've presented this to us already at the primary care leadership group, and I'm really grateful for the work you've done and the detailed engagement that you've went through. Actually, and I can see it's still a work in progress. We gave you some really good feedback, I think, in the day when you presented this to the primary care leaders, particularly around the importance of workforce, putting the family centre, and that reflected in some of the comments already made, and also about empowering and supporting people and using out of care settings. And my kind of overriding kind of feeling is the need, as you rightly said, the need to be bold and to be almost radical in the approach. And I think to do so, we need to move away from some of the more traditional health outcomes that we target and look at, which in some respects actually put organisations more into silos as they're driving on different targets. And what I would like to see is a more explicit intent in the strategy to drive integrated working. And I know that's what we're all about, but having something in the strategy document which explicitly states that or quantifies what we mean by integrated working, so involving primary, secondary, community mental health services, involving social care, the voluntary community sector as well, and making that for the patient journey seem more joined up, and addressing the health inequalities and reaching into the community. All the targets which we want the strategy to actually deliver on, but maybe having something more explicit and being more, if we're going to be bold and radical, I think we have to be, that has to be reflected in some of the wording in the strategy document. But that's all, and thank you again, John T, for the time and hard work.
Thank you, Gavin. And then the last comment I've got at the moment is Christopher.
Thank you, Chair. My name is Christopher Evans. I'm the Chief Officer for Community Links Bromley, but I'm on here as a representative of the Voluntary and Community Sector Partnership in South East London. Just to say, we've been integral to the development of the strategy, and so we very much welcome some of the broad principles and ambitions. I was on the call last night, and the commitment and engagement of the partnership and the leadership team at every level, I think, has been excellent. I note the plan next steps, and I think the principles of engagement, we just need to ensure that we continue to embed and continue the process and the journey that we've been on so far. I think we do need to ensure that the process continues to be inclusive, and we continue to engage with the seldom heard communities. I think there's something about partnership. It's not just the health service. We've heard it's not just social care feel left out. I think we should think about the voluntary and community sector not as an addendum, but an integral component of the system. And in that regard, I think the commitment to prevention is really important. And I think one of the things we do need to sort of have an ongoing and constant conversation is about how can we ensure that we mobilise and continue to mobilise that community capacity. I say that because on the ICS website, there's a reference to 6,000 community organisations in the system. I think that's the tip of the iceberg, if you like. And I think there was a commitment to engage and mobilise, and that was really important during the pandemic. And it was important because there are clearly issues of trust with engaging with certain parts of the community, certain hard to reach parts of the community, and it's important that we don't lose that. The voluntary and community sector played a really pivotal part during that period, and indeed now during the cost of living crisis. The establishment of warm hubs across southeast London and the voluntary and community sector, but also the faith communities themselves have also been pivotal to that. So I think there's an issue about how we continue to mobilise and engage with that sector. I was on the call last night, and one of the points one of the organisations made was how to get more out of small community groups to aid prevention, and to think about actually what does support look like there. The final point I'd like to make is there are a range of community tools that do enable us to access that resource. Bromley, we use Simply Connects as a tool. That enables us to reach to 500 organisations in the borough, delivering over 1,000 activities. We need to harness the resources that are there, because I suppose what I'm saying is there's a huge asset base there that we can build on, develop and grow, and it will make a huge amount of difference to the prevent agenda. So I think we're on the right path. Let's build upon it, really.
Thank you, Christopher. Jonty, I'm going to keep going around members of the partnership. So hopefully you're managing to keep your notes. I appreciate it's hard to come back and everyone go, but I think a really helpful commentary coming back from people. Lots of positive points and some really thoughtful ones too. So Hugh, would you like to go next?
Thank you, Hugh Taylor, Chair of the boards at Guy's and St Thomas's and King's College Hospital. Just to say, I mean, can I echo comments that others have made? I think this has been a very participative and engaging round of consultations, and I think augurs well for the future. I think I just make the point this is still pretty high level, and March is quite ambitious, because if this is really going to mean anything, it's got to be pretty concrete, I think. Otherwise it's just blah, if you know what I mean. We all want all these things, but I think that places have really got to be given a challenge which then they can contribute to. You know, I'm a bit of a crack record on this, Jonty, but I'd abolish all these references to sectors, you know, primary, community, hospitals. It drives me mad. And I think it's going to be increasingly meaningless in the way care is delivered in the future, and I include social care in that. What we want is an integrated approach to these things. So I do hope that what we can do is set a challenge, a set of prioritised ambitions for the ICS, which then places follow through on in exactly the way that colleagues have been speaking. In other words, to throw our organisational and sectoral issues to one side and really organise on behalf of the citizens of that particular patch against a common priority. So I think I would be clear and precise on the strategy and priorities, and they need metrics and measurables. And then second, I'd be generic in encouraging, and deliberately so, in encouraging full integration in the how it's delivered. Thank you.
Thank you, Hugh. And Richard.
Just to some extent, I think Hugh's already made part of my comment, Kieran, but it's listening to everyone around the table. It's important in this that, yes, we focus on the priorities, how we choose these, how we approach them. But equally important is our approach to the enablers, how we work as an integrated care systems. And that goes way beyond priorities. So I think picking up on points that both Gavin has made, that Christopher's made as well, there's an element in this strategy and in our approach, there's got to be about ways of working. So what does integrated mean? How do we work in an integrated way? What does working more constructively with the voluntary and community sector actually mean? What does that mean about how we commission, how money flows? So I think sitting alongside all the priority work, which is critical, is this broader enabling work, and this broader approach has got to be part of the strategy as well, Kevin.
Thank you, Richard, and everyone for some really helpful comments there. Let me briefly recap and then hand back to you, Jonty, to come back on those. So obviously points from Christopher and David about the role of the voluntary sector and social care within the strategy. I think they are very much in the thinking behind this document, and just I think people seeking reassurance that that's there in the reality. We've got Paul's comments about how do we make sure that this adds up to supporting people through their life journey to have good health and well-being. Jill's comments about taking a values-based approach to care and the focus on the outcomes and experiences for our residents. Gavin's comments on integrated working and how we make that explicit. Hugh's on being clear about the outcomes we're trying to achieve and how we will measure progress against those outcomes. I personally add to that being clear about reduction in the inequalities and outcomes, as well as just the global outcomes, but being open about how do we actually integrate care to allow people to be innovative and creative in solving those, and Richard's final comments as well. So Jonty, would you like to come back on those? After you've done that, I think I just want to take us back to people to make sure that we're happy with the mission and the priorities. So perhaps when you finish, Jonty, if you could put the priority screen back up in particular, so we can do that.
Absolutely, I'll ask Ben to do that in a second, and thank you. So look, I guess it doesn't surprise me at all that this group is kind of champing at the bit almost to want to see the detail that we absolutely need to get to underpin this. So first of all, I just wanted to say thank you for all of those comments. I'm not sure that I'm going to address all of them in detail, but I really will ensure that they inform the sort of ongoing iteration of this. I do think that one of the themes through the comments that you've already alluded to, Kieran, is this, and it goes to Hugh's point, I think, about sort of abolishing references to sectors, because a number of people were really talking, I mean, I think actually it speaks a little bit to what David was talking about as well. When we say care, we mean care. we are not referring to a particular organisation or a particular part of our system anymore. How do we really draw that out in this? Because I think that is the intent. And apologies if certainly in my presentation I haven't captured it adequately. We need to, because that is absolutely kind of at the heart of what we're trying to articulate here. Is it requires a fundamentally different approach. It requires an integrated approach, and that does need to create, if you like, that sort of generic how, or that theme that Hugh was alluding to. And I think that's come through in a number of the comments. Certainly I picked that up in Gavin's comment again. How are we more sort of explicit about that change in the way in which we will need to work if we're really going to be able to deliver on that? And that means all of us. And the all of us is a different all of us to how it has felt before, which I think is why Richard is quite right, that as part of this we absolutely have to think about a different way of working and what that might mean. A lot of that, I guess I just wanted to flag, is intended to come out in the next phase of this. I completely acknowledge that at the moment this does feel quite high level, but in a sense we wanted in the first instance to make sure we're on the right track, and I haven't heard anybody so far say no, these are not priorities that we recognise, these are not things that we think reflect what we experience when we talk to our constituents, when we talk to our patients, when we talk to the people that we engage with. So it feels to me as though that bit is fine, but actually the challenge that's coming back through this conversation is much more around the how. Now, how do we make it meaningful? How do we ensure that we make a difference that we can measure, a difference that is meaningful to the people who are on the receiving end of care, to our patients? How do we ensure we identify outcomes? And one of the things that I wanted to flag in terms of outcomes is, I think, and maybe this goes back, Paul, to your conversation about sort of the life course, but also more to sort of making sure we look at this across whole pathways, is one of the things we've got to do is we've got to shift the way we measure things from being from relating to activity that's associated with particular parts of our system to measuring things that relate to outcomes that require all of us to work differently together. So I think that shift that Jill is encouraging as well to an outcomes approach is what will start to drive that integration, because an outcome, almost by its definition, requires us to have all worked, all contributed in some way to that. Activities and performance metrics often only require one part of the system to work in one particular way. And I think, again, that goes back to Richard's point about what is it that's going to be different? What's going to drive a different way of working this? And I do think that outcomes piece is going to be one of those elements. So very happy from my point of view to take on all of that feedback. In fact, I'm really encouraged by it, and I'm encouraged by the sense of ambition that I've heard. I do think that also came across in conversations with primary care leaders and others across the system, and we were challenged last night, I suppose, just to kind of finish with. So the conversation that we had last night, there were people who have heard these promises now for 28 or 30 years, people who have often children, family members with significant care needs, who have been waiting to see a greater level of integration and collaboration within the system, who are constantly challenged by the administrative boundaries that are put in place through the transactions that we've created. And their challenge back, I think with a legitimate amount of cynicism, was what's going to be different this time. And I think this next phase really requires us to be able to say what it is that is going to be different and how we're going to deliver on it. So I hope that's helpful, Kieran. I absolutely take on board the comments that have been made.
Thank you, Jonty. And I just want to draw your attention to the point Christopher's made in the chat about the need to produce a memorandum of understanding with the voluntary sector in South East London and how we'll work together. Andrew, you wanted to come in next.
Chair, just in anticipation of you bringing us back to, I think it's slide 13, just to check that we, so there only slight, well, not criticism, but just to make clear, this item sandwiched between the state of the nation and then a discussion about getting into the medium-term financial strategy. And I guess when we were putting these papers together, the bit that's not getting amplified much is the financial sustainability piece in this. So I think one could sign up to these very readily. And I'm glad people have made the comments on inequalities and on the ways we do things around here, because they're captured on slide 14. So just in the checking back, Chair, I wanted to make sure that the financial sustainability piece on 14 is also recognised, because I think that then forces the issue on doing things differently. Adding together all of our deficits doesn't make a surplus, is my learning through budget management. So
really important point, and that, you know, obviously we're coming back to the money shortly and the overview of what we have and how we spend it. Jonty, can you remind us of the timescales, what you need from us specifically today? And I suppose the other question that's really important to ask at this stage is, clearly we want the right strategy for South East London that we're all signed up to. Equally, we know there are things that we need to do in order for the government to sign off and the NHS nationally to sign off our approach. So just if there's anything in here that you need to highlight to us about what this document needs to do to get the sign off that we obviously need to achieve.
Apologies, I think I just muted myself. So, at this point, obviously we have not, we're not bringing to the group a kind of final document for sign off. We are really wanting to test the direction of travel, whether we've identified the right themes to now, if you like, do that additional work that we've been rightly directed to do by this group across those themes. I think we are going to need to do some more work and probably work with members of the board around kind of what it means, and we'll get into this in a second, I think, with the financial strategy, with the medium-term financial strategy. But what does it mean to be a priority, and how are we going to start to deliver that, and what will it require? Also, the relationship between this group and the Integrated Care Board, which goes back to Jill's question earlier on, in terms of ensuring that it's delivered. So at the moment, I think we're looking for the support of this group to move on to those next steps. We don't have to submit a final document now by the end of the year, which was the original timeline. There is an expectation that we have an interim. I don't think, others may tell me if I'm wrong, that there's been a clear definition of exactly what that needs to involve, but to be honest, I think we have quite a lot that we could ensure demonstrates that. I think what you would expect is that we are able in that interim document to also at least give some indication of what it will mean to how we would work differently as a partnership. But in the spring, I would anticipate coming back here with the full strategy, having engaged further, taking on board the comments we've heard today about ongoing engagement and not losing momentum, because I think we've done really well at ensuring we've involved people in this. So we would be coming back then with a final strategy. I suppose I didn't want to lose the point that that Hugh was making as well, which is that we also kind of need to be realistic in terms of timelines on some of this. So again, when we come back, I think we need to be more explicit about what are the timelines on delivering against some of this, what will it require, and by when, because at the moment it's probably a bit too easy to sign up to. We need to get into something that feels a little crunchier, I think, in the spring. Is that okay?
I think that's really helpful. I've got one last question, Paul, you wanted to come back. You're on mute, Paul. Or at least I can't hear you, I'm afraid. I assume, Jonty, can you hear as well?
I can't hear at the moment. I think there may be a technical glitch.
Not sure what the glitch is, Paul, but perhaps you're able to put something in the chat, which I think might be what you're doing, judging by things. So I'll just wait for that to pop up. So I guess what I just want to check now with people are please do type the question, Paul, if you're able to. So what I haven't heard is any disagreement with either the mission or the principles or the priorities. And Ben, if you're able to just put that slide up with the priorities so people can remind themselves of them, that would be really helpful. I think there's obviously a very clear steer from people in this discussion about wanting to really bring together how we provide care in the round, taking on board Hugh's points. And I think if we can make sure that the final strategy really tells that story in a clear way, that we understand what we mean by doing that really effectively, and whether you're in the voluntary sector, the social care sector, or the NHS, that speaks to you. There's clearly a need to come back and be clear about the outcomes against these 5 themes that we now have on screen. And then beyond that, we'll also need to come back at a later date and look at how we will measure progress against those outcomes and have the right measures that are going to drive us working together to achieve them. I had a couple more questions that people wanted to ask. So Paul has put his question in the chat, which is, my question is, how are you testing scenarios? For example, someone needing acute care, intensive enablement, and limited intervention to deliver our strategic objectives. And then I'd also bring in, oh, sorry, apology. Just trying to scroll back to see who it was. Stephen, I think you wanted to come in.
Yeah, thank you very much, Chair. I'm Stephen Kitchman. I'm the Director of Children's Services in Bexley and the DCS rep. Just to kind of come back on some of the earlier comments, I really welcome the strategy as well, and the direction of travel, and certainly I think the priorities do resonate with the needs that I would identify certainly across South East London. I think just some of the earlier comments as well. Sometimes we can be talking about the same thing but mean something different, and I think certainly the priorities of prevention and early help really important, and we raise that in the strategy. Integrated working, which was a comment, but I think as we move into further iterations, sometimes we can be talking about the same thing but mean something quite different, and I think in terms of definitions and teasing some of those out with the kind of next steps work, that would be really helpful. The other comment that was made earlier was about silos, and I think in terms of the priority of certainly adult mental health, really important, but certainly for children, the kind of one of the main referral reasons for more statutory services across the southeast is children whose parents have a mental health support need, and conversely for parents with mental health who have children. And I know that there's been some excellent work within SLAM in relation to looking at a kind of think family approach, a whole systems approach. And I think one of the opportunities for the strategy is to make sure, as a colleague said earlier, is that we move away from the silos to get some join up so that we can actually respond to the impact of some of the needs that we've described on families as a whole, really. And I think again there's some of the implications for that for children equally who have a mental health support need. Thank you.
Thank you. So I think there collectively there's some really good points to take away and build into the final strategy. If there's anything that you think there's a question you've got on that you need clarity on before you go away and do that work, then please do ask that now, Jonty. Just as a small, I suppose, point of detail, looking at this slide that's up at the bottom, the last principle I think perhaps fails Hugh's test, where we talk about primary care, where actually we're talking about care in the round, aren't we? I think it's a good example of where we just want to make sure that we've got that consistent focus and language. But I haven't heard anyone to argue against these 5 priorities or against the overall mission or the principles. So having said that, I think where people are broadly supportive of them. Now's your opportunity to speak up if you have any reservations, so please do put your hand up now while you still have the opportunity. But Jonty, back to you for a final response on the things you've heard.
Thank you, and again, to be honest, just incredibly helpful from my point of view. So I think there's something, Paul, about taking your suggestion about using particular scenarios to actually test back with. So we're about to establish these sort of expert groups who will look at particular opportunities to really improve care. And I'm wondering whether one of the things that we could helpfully do then is to identify, and certainly we've heard through the process of engagement a number of people talk about their personal experience or that of their family members. I think it would be really helpful for us to think about how we essentially tested the proposals that we make against whether that is going to make the kind of difference to those people who, as you have rightly identified, are potentially having to undertake pathways that cross over between acute and rehabilitative care and community sector. So I suppose I'm going to take that, if you wouldn't mind, as a suggestion about how we might test back some of these proposals to ensure that actually we are going to make a difference. I take the challenge, Chair, around also our continuing language, and I think there was something in what Stephen said about how we think about definitions and how we draw some of that out in a way that also relates to some of the comments earlier from David and others about the way in which we speak, and sometimes it's easy for us to assume that what we mean is understood, but it isn't always, and how we really use the strategy to start to use different language together and start to get rid of some of perhaps the language that has maintained difference within our system and move towards language that supports deeper collaboration. So I think I would take that on board. I just completely agree with this challenge around silos. And those silos exist across individual pathways of care, but equally within families. So I think there's a lot of learning that we can do from our organisations, and I suppose maybe the final thing is not to lose the point that was made, and again has been made consistently, which is that we have everything that we need in South East London, certainly in terms of the expertise and the understanding about how to do this. We really do across our organisations. We've got phenomenal assets across our communities and voluntary care sector, but also within our large universities and academic organisations as well. So there is something about ensuring that we surface that within the strategy as well, and how we draw upon that to really demonstrate that we can make a difference. So I hope that's helpful. I'm really appreciative of everyone's contributions.
Well, thank you very much, and thank you, Jonty, to you and the whole team who've been working on this. The approach you've taken, that hard work is obviously paying off and getting to something where you've got a very wide range of interests around this virtual table today, paying back a great deal of support for what you're doing and the approach you've taken. So we'll be looking to obviously continue the conversation with individual partners over the coming weeks about this work and to bring back the strategy to a future meeting so we can look at the next iteration of it, so we can agree the right strategy for our area. I guess in doing so, obviously some really clear messages in there about working through the outcomes that we want to achieve in each of those 5 themes that you've put up on the screen and that we're working towards. Importantly within that, how those outcomes will help close those gaps between the different parts of our community, and whether that be those be that based on deprivation or our Black, Asian, ethnic minority communities, or indeed people with learning difficulties and autism and other things. I think important that we understand what closing those gaps means and how we then will plan to integrate services within each of those domains. I think the other thing that came up in that conversation that we don't want to lose sight of course, that we've talked a lot about as partners, is that split between what is best led at the South East London level and what is best led and delivered at the borough level, and the interplay between those. So I think the more the strategy is clear on where we're looking to drive those things, borough-based or South East London-based, the more we'll all be able to work together to deliver it. So thank you very much for everyone's contributions. We will come back to the strategy at our next meeting. So I'll take us on to the next item on the agenda, which is the approach to allocating resources in South East London, and I think Mike was going to talk us through this one. Mike, would you like to introduce yourself and the item?
Thank you, Kieran. So I'm Mike Fox. I'm the Chief Finance Officer for the South East London ICS. And the next item on the agenda is around the approach to the allocation of resources in South East London. And I suppose just following on from Jonty's approach, obviously the development of an integrated care strategy, we also need to develop a medium-term financial strategy. And within that, setting out some of the principles of how we would seek to allocate our resources and align those allocations to achieve the strategic objectives that we're going to set. But at the same time, the medium-term financial strategy will need to reflect and support the ICS in securing financial sustainability in the medium and long term as one of our priorities. Within this, we know that the context both for the NHS and our local authorities is extremely challenging. We have an underlying recurrent deficit within the NHS and extremely challenging financial positions for all our local authority partners. So we must understand that that is a reality that we face. But with that, we will be seeking that the strategy and the medium-term financial strategy puts finance as an enabler, supporting the delivery of our overall strategic priorities. But again, with the reality that at times the financial position will represent a constraint to some of those ambitions as well. So in that, our investment decisions are going to have to be demonstrably driven by considerations of our strategic priorities and seek to gain best value from all of our funding and investments, not just the additionality or changes that we might seek to make. We know that our current level of investment across our system and different organisations and different types of care isn't necessarily driven by population need, but in cases more historic allocation methodologies and business cases that have been made commissioning decisions historically but don't necessarily reflect the here and now. So how does our medium-term financial strategy and our strategy enable us to change that? We've in the past committed to shift resources within our system along care pathways to more community-based care and investment in prevention and inequalities. But in reality, historically we've struggled to do that. So how do we make sure that this is a change and we set ourselves the challenge in the medium-term financial strategy and our strategy overall to actually deliver on that promise and ambition, and shift resources from treatment to prevention, shift resources so that it addresses historical inequalities that have been created through historical decisions. And so that is clearly our main priorities. Ben, I don't know if we can put up the slide that had the questions for the ICP members. These are the broad questions, and we've taken these from the wider discussion document that I think partner colleagues saw before this meeting. And we'd really welcome comments or challenges on what was in that document and also along these questions. So are we committed to, oops, Ben, have we lost the slide? Thank you. What principles might we wish to underpin the development of the medium-term financial strategy? What is the appetite of members for making changes to the way we allocate funds to address inequality? Not just inequality in investment, but actually I think inequality of outcomes, inequality of access, which is more important necessarily than inequality of investment. And what opportunities do we feel there are for greater closer partnership working to make the best use of our resources to enable these things? So Kieran, it's much more of a hearing exercise, I think, than me talking to people exercise.
Thank you very much. Very helpful, and of course really important to start at the beginning understanding the money that sits behind the priorities we're setting out. Have people got questions and comments that they would like to make? I guess I will use Chair's privilege to reiterate mine at the beginning, which is that one that stands out in the State of the Nation report, that we have higher than average levels of mental health need in our populations, but lower than average mental health spend. That's something I think we would need to look at as a partnership together. Are there any other comments that people would like to raise? Yes, I see Richard, if you'd like to come in.
When I suggest I'm going to comment about the financial stuff, I'm sure the Chief Financial Officer starts to get a little bit worried, Kieran, but I just think at some point on this, we'll have to set ourselves some quite clear ambitions. So we have said for years that we want to move investment downstream, but we haven't really achieved that. And it may well be that we need to just, between us, work through something quite crude that says, actually, the percentage of investment in prevention at the moment is X. We want it to be X plus Y within 5 years' time. I mean, if we sort of set that sort of stretch ambition, now in doing that, clearly we've got to recognise what existing demands are. But I just wonder whether a few a few clear stakes in the ground around things like that, and what we should. And a similar one maybe about the type comment you've made about relative investment in different areas compared to need. Different areas of not geographic areas, but different areas of activity compared to need, and whether it's really worth us trying to work through this and come up with a handful of sort of say key stakes in the ground that maybe Mike and colleagues could work to. And I guess the other comment I think that I'd make on this, Kieran, is at the moment we haven't really got a very good picture of combined spend on health and care, going back to David's comment earlier, across South East London. So although we're clearly not in a position of directing spend that's not ours, I think to really do this financial strategy right, you've got to try and bring all the pieces together, and I'm not sure anyone's really succeeded in doing that yet. So just a couple of suggestions.
Thank you, Richard. I've got some comments people are keen to come in. So Paul, with the glitch on sound, has put his point in the chat, but really importantly made one. Financial distribution should be based on clinical need and using data of our unique challenges in South East London. Prevention as invest to save model to improve the whole life pathway for everyone irrespective of income or background. So obviously that's absolutely about your point, Richard, of being clear on what is the evidence actually telling us about where we've got the spend that doesn't actually map to the improving the healthcare outcomes that we are committed to delivering. So I think if we can do that work together to be clear about actually where are our outcomes not as good as we would expect them to be for our residents, and where the money is failing to match that, that would be really helpful for us to make an informed decision. So let me bring in Catherine and then Gavin. Catherine, if you'd like to introduce yourself.
Hello, hi, I'm Catherine Rama, Director of Public Health in Lewisham, representing Director of Public Health on this call. I think it's just comment that it's really positive to hear conversations about, first of all, in the strategy prioritising prevention and wellbeing, and then followed up by a conversation about how we might move resource to support that strategic ambition. I think it's just refreshing from a public health perspective. And I think Richard's challenge about trying to set some potential stretch targets around where we are spending on prevention, both across typical NHS, but local authority public health as well, would be really welcome. So I'm just happy to support that work, but yeah, just wanted to add those comments in there. Thank you.
Thank you, really appreciated. And Gavin. Hi, Gavin, did you want to?
Yes, I do want to. Sorry, can you hear me now, Chair?
Yes. Yeah.
Yeah, sorry about that, delay getting off mute. My comment about this, unfortunately, is a little bit similar to what the comment I made previously, if you don't mind, in the sense that the incentivisation that we've had in general practice, it feels like to me it drives siloed working. So it's say if you've got to drive a blood pressure target or a diabetes target, it very much is seen within the organisational boundaries which you're operating on. So what I'd like to see is financial incentivisation coming through very explicitly for can you deliver an integrated service. I think a way which we could do that, as I said previously regarding the strategy, is more clearly defining and potentially quantifying what we actually mean by partnership working or an integrated care service. So quantifying it and then, as I say, financially incentivising it. I think if we don't do that, people are still going to work within their organisational silos and deliver on those targets independently.
Well made point. I've got Andrew and then Hugh. Andrew.
This is three very quick points, so maybe notes to self, Chair, if that's okay. Just the first one, just so we don't mislead each other as partners. I think it's really important, a bit maybe to Gavin's point, but just a wider one. Just understanding the art of the possible. Some of our investment decisions that Mike has talked about historically in the future will be driven by external parties or circumstances as well. And I just think in a partnership the size of ours, geographically, but also spread, just a clear understanding of those things will be important in the way we do things with each other. But they change week to week in my world at the moment, I'm sure in yours as well. So that was one thing, finding a way to do that. Secondly, the implication of some of the positive things we've said and Catherine has just reflected on, it does mean we'll have to be very, very diligent in the way we are in some parts of the business and not others on return on investment. Some of the yes, short-termism, but also type of investment we're making, being able to make a clear judgment on that, and we'll need a greater sophistication of analysis than I think we are used to on the health service at least. So, and then the third one is just I'm sure Mike would make this point anyway. I think he kind of has made this point. In a financially constrained environment, a pound's one place is a pound not somewhere else. So there'll be partners around this table that will be asked to make really quite difficult choices off the back of some of the positive ones we're making, and so that we're very clearly sighted on that when we come forward the medium-term financial strategy, not to state the blindingly obvious, but if you see in the state of the nation we've got a disproportionate spend, we would have to shift it rather than grow it. I don't think there's an opportunity to grow it. So just 3 points from me, Chair.
Thank you. And Hugh.
Thank you. Andrew's almost taken the words out of my mouth. It's easy to say this. I can say, I'll say this now. I'm a bit of a skeptic on some of this. I spent 25 years in the NHS and that's about to come to an end. And we've been saying this to ourselves for 25 years and not doing much of it. And that's for some pretty good reasons. So this isn't because there's some great bureaucracy somewhere trying to stop this happening. It's because it's very difficult to do. And that's because our system has never matched demand and supply. So every time you make a productivity gain anywhere, you almost immediately fill it up, and that's true across sectors and it's true within sectors. So that I'm not trying to be too negative about this, but what has always impressed me is the ability to do quite a lot with relatively marginal but important pieces of resource allocation. And I would cite for that, for example, the creation of the virtual ward model, the hospital at home model, which was created, which has undoubtedly been beneficial across, I can only speak for Lambeth and Southwark on that, and certainly repressed demand for beds at St Thomas's and Denmark Hill. But it's not difficult to keep filling the beds, is what I would say. So I do think we should look for, I don't know about growth exactly, but incremental shifts here and wise and targeted earmark funding for particular things, and I think we'll do quite a lot that way rather than just making grand promises to ourselves, which I would bet a small margin we won't deliver on.
Years of the arrows of misfortune.
I hope you're not too cynical, Kieran, but I'm just echoing a little caution here, that's all. Really, this requires proper investment from national level. And it's been cutting it in areas like universal services, for example, which are so obviously what should be a priority.
Yeah, very important points that were well made. I've got a last comment from Michael.
Thank you, Kieran. My name is Michael Nutt. I'm chair of Bromley Healthcare. I just wanted to ask for a comment, if I could, please. I think a number of people have commented in different times. I think Richard Douglas commented about the need for some key stakes in the ground, to use his line, about some really challenging targets. I agree with that. I think we've heard from different people, from Hugh and others, about the need to challenge the barriers between sectors and different organisations. We've heard of, obviously, the need for really smart decisions about efficiency management and money. What I haven't heard yet is a real understanding of our digital strategy. I know that's in process, but I think it would help us speak about efficient learning across the system between different organisations. I think it would enable us to make some smart evidence-based efficiency decisions, but I'm not sure yet where we've got to in the creation of that strategy, and I wondered if we might have some comment on it.
Thank you, Michael. Important points. I think this is obviously the beginning of a conversation in this area about the money. It feels to me like the things that would be most helpful for us as a partnership was to be able to do some of that work, accepting the difficulties of doing some of it, to be understand where relatively we think we're perhaps under investing. There are lots of areas where we would ideally all like to be able to invest more, and let's be clear about that. But relatively speaking, are there areas that we think should be priorities following on from the priorities we've set in the strategy, where relative to other places, for example, we appear to be under investing, so at least understand that. Accepting Hugh's comments about the challenge of moving money around the system, I think we then need to look very practically at how we can and can't invest in those areas, as well as the comments made that obviously some money comes to us with very strict strings on it, and even if we think it would be right to move, we're not able to. So I think that would be really helpful. But if you'd like to come back, and on the digital strategy particularly, I'm very conscious there is at the South East London work on our digital strategy, on our strategy around people. Obviously, comments raised at the beginning about the challenge that we have right now. Even if we had all the money, we wouldn't be able to fill the posts because we don't have people to do all of those roles at this point in time. Similarly, I'm sure partners will in the future have questions about estate and making sure that we're able to have the right buildings to provide those primary, secondary, etc. services. But Mike, would you like to come back for now?
Yes, thank you, Kieran. I'll just start off with maybe a bit of a warning to my boss, Andrew, that I may ask him to address the digital strategy piece at the end, as I'm sure he's far more sighted than I am. Just a few points I'd like to sort of come back on, and I think picking up on your point, Kieran, initially about the specifically mental health, but I think you had a broader point. But if I just the specifics around mental health, we are aware in the creation of our medium-term financial strategy that there are certain areas of care where we are underfunded historically, and we know the demand is there. We are committed to maintaining the mental health investment standard as a minimum for the trajectory for investment in our mental health services. We're also committed, I think, to any primary care investments as well that you would be expecting this to be. So hopefully that gives you a little bit of assurance that we won't be seeking to make the headroom, if you like, for shift from those services. I think just Richard made some very important points, and I think some very good points about, do we just need some markers in the sand to stretch ourselves? I think we do, and we will. And I think it quite well dovetailed with Sir Hugh's points about the challenge of doing this. We've all been through many iterations of these things where we've challenged ourselves to start moving resources from where it currently is to where we would like it to be, and changing inequalities. And I think that's part of the balance we're going to have to stretch about how much is ambitious, but how much is unrealistic as well, given the challenge and history around it. I think as well as a system, we will all have to be signed up to the delivery of that. As I think historically you'd have seen, when things become extremely challenging in tactical annual budget setting, these sorts of investments are the ones that come under the easiest and quickest scrutiny, and we need to avoid that again. Otherwise, we'll repeat the errors of history, if you like. So I think we do have to make sure that as a system we're brave, we're realistic, but also we hold each other responsible for delivering the rest of the financial plan to make sure that they don't get removed and reduced. I won't specifically come back on Gavin's comment about how do we incentivize the whole system. I think it's a really important comment, and we maybe need to take that away and think about how we build that into some of the allocation methodologies. And yes, I am going to slightly throw the digital strategy to my boss, if that's okay.
I think John T and Andrew were competing with each other to answer that question. So whoever would like to.
Well, since I'm being called out as the boss, Kieran, I'll start. Can I just make a point, just specifically on the incentivisation point? This was to my point around national contracts and local contracts. So I actually think that the idea of aligning incentives is something we've been rather good at in South East London where it's possible. In public, we decided we would like to take on a delegation of pharmacy, opticians, and dentists last week. We've already had general practice, but to be clear, some of that is a national negotiation we need to influence. Others of it is more within our gift, and of course that will change over time. So just to set expectation on that. 25 minutes before this meeting started, I named our medical directors as the leaders of all things digital. So I'd feel neglectful if I didn't ask John T to comment. The only thing I would say is that we do have a digital strategy and strategic statements, that it lacks the chapter that says, so what, because of this we will need a different workforce that, or because of this we will find a different financial solution that helps us. So I do think we've work to do there, and I think that's what the Jonty's slide 14, which is the sort of the cross-cutting themes and enablers in the previous presentation was directed at. So I think we are starting this with more to say. All jokes aside, Jonty gives us a lot more thought than I do, so I'll hand to him.
Thanks, Andrew. I don't know about a lot more thought, but as you know, it is something that I kind of feel quite passionately about. And Michael, I've benefited certainly from lots of conversations with you in thinking about this. I guess, look, so I mean, we do have a digital strategy, but I think what we are kind of coming to recognise is that a lot of our priorities from a digital perspective have been defined more by a set of requirements that haven't necessarily been arrived at collectively. And I think the whole process we're going through now to decide together what it is that feels most important should then inform our digital strategy, and it has to be that way round. I think for too long we've tried to develop digital strategies based on what we think we need to do digitally, rather than thinking, as we had the conversation a little bit earlier on when we were talking about the strategy, what is it that would allow us to work across organisational boundaries differently? What is it that would allow us to empower people in terms of looking after their own health and care and well-being more effectively? What is it that would allow us to better identify those people of highest need and proactively go out and support them? What is it that would allow us to personalise care and to ensure that digital doesn't result actually in people feeling further excluded? So I think there are a range of things that we need to think about in relation to the commitments that we're making collectively as a system that should then inform a digital strategy, because a digital strategy should enable that. It shouldn't be the thing that defines that. So I think that's really, from my point of view, key to take away from this. We need to sort of hot on the heels of our strategy, we need to follow up with a very clear set of priorities digitally that we would deliver on as a system. But at the moment, a lot of our priorities have been around how we connect up the different organisations that are part of our system in a way that allows us to support a more seamless experience of care for patients, and also allows us to understand the needs of our patients by looking at the data that's generated through some of those consultations, but also through other services within South East London, so that we can better target support in the way that we did around, for example, vaccination in the pandemic, to identify those parts of our community where we would want to provide additional support and resource. So I hope that's helpful, but I'm very happy to pick that up, Michael, and get your guidance following this.
Thank you very much, Jonty and Andrew. So I think really helpful start of a conversation about resources there. I know we enter this with, I think every organisation around this partnership struggling with inflation and rising pressures on many of our services, and so having a conversation about moving resources in that context is a very difficult thing to do. But I welcome the positivity of people about looking at how can we get investment into those areas where we know we need to make the most progress in improving outcomes. And I think I particularly want to go back to Councillor Bell's points about us having a very evidence-based approach to that, and in order to do that, the only way we can do it, and also welcome that the focus is on the outcomes, is the place where we want to really be focused on across our South East London system, and the work on the digital strategy amongst others to do that alongside the finances. So that's the end of our main agenda. I want to say, before I go into the final part of the agenda, which is public questions, thank you to the whole team for the papers you put together, but more importantly for the work you put into talking with partners around this table over the past months to get us to this discussion today. And a thank you to everyone around this partnership for entering into this discussion in such a positive way. We know that this partnership is not going to be an easy thing to make work. It's going to be reliant on all of us as partners playing our part in making it effective, and in particular playing our part in making sure that we're focused, absolutely focused on improving outcomes for our residents their health, their well-being, and especially those who are high at risk of having poor health and well-being. And absolutely, that's what I've heard in this conversation today. So I want to thank everyone for their contributions. The last item we have on the agenda is some public questions. I'm going to hand over to Ben in a second just to outline our approach to taking public questions at this meeting. Whilst I do that, I just want to say if there are anyone who's already submitted a question, and Ben will be able to outline those questions. If you have a follow-up, we do have just a few minutes to take any follow-ups on the responses you received. If you do have one, please, if you could type them in the chat, then we will respond to them. If you could do that now while Ben's talking, that would be greatly appreciated. Ben, over to you.
Super. So my colleagues should just now open up the Q&A function for members of the public to write in any additional questions that they have. If we don't have time to answer them now, of course, we'll provide a written response. While members of the public are writing in any new questions, we received 3 questions in writing in advance. They all related to the setting up of our local care record, which is, of course, is a single record of people's health and care that should be accessible by organisations and staff across our system, and also about how we are planning to use and protect people's data. And there was also a question on how we are out on data security. So we have just now today, I think, published quite detailed written responses to those questions, which should be online now. They're really important questions. I think the headlines are that we're working with NHS trusts across South East London on an electronic record. We're also working with integrated care systems across the rest of London. We're working with EMIS, the primary care electronic record system. We're raising awareness of our local care record with quite a range of things, including short films, posters and leaflets. And there's various continuing engagement on how we're using people's data, in particular through the One London programme. So my sense is I should probably stop there, Kieran, refer people to a much more detailed set of written responses and see whether we have any Q&A questions. I can't see any new questions, so perhaps assuming nothing comes in, we'll direct people to the responses online.
Thank you, Ben, and yes, certainly happy to do that. And important to say here, as you said, Ben, we have some questions about a question about the setup of the partnership and who's been involved in it, and the wider integrated care system. Important that that is and there's a full answer to that. So I'm just hesitating because I think there is a written question that I'll come back to in a second. And then there's the clear questions about the management of patients' data across South East London. Important to say that that's something that the Integrated Care Board has the leadership on, but the answer is nonetheless here in the written response. So I have one more question, written question here, which is: have you considered interdisciplinary working to overcome knowledge silos, overarching frameworks developed for Michael Marmot's work on social prescribing, for example? Really well made point, something that has come up a little in this conversation, but I would welcome responses to that. And Jonty, if you're still there, perhaps you'd be best placed to respond.
Yes, so really important. I think if I've understood it correctly, to really think across a broader range of disciplines as well than we necessarily have previously. So one of the things we heard very clearly last night from local residents and the engagement that we were carrying out was the impact that new social prescribers or care navigators have been having in helping to ensure that people, particularly who have quite complex needs, are able to access services more effectively. And very often these people are able to, because they've got quite a deep understanding and knowledge of what's available locally, they're much more able to kind of connect individual patients, people who have particular needs with services locally. So there's something about both expanding our understanding of our workforce, particularly given some of the challenges that we're experiencing at the moment, but then ensuring that we support the sort of, so I've talked a lot about sort of multidisciplinary approach. So we support people to work together as a team, allow them to effectively understand each other's perspectives and increasingly blur some of the boundaries that we've been talking about today. So I hope that that helps, Kieran, but I'm happy to provide a more detailed response, obviously in writing, but I think it's a really helpful question.
Thank you, Jonty, and I see David Kirk-Thornton's also added a comment that we're modelling interdisciplinary working in this partnership in many joint teams across South East London. The more we develop that, the better a path to integration. And we clearly have some very good models of that already working in different ways in different patches that we need to build on. So I'm going to draw the meeting to a close at that point. I want to say thank you to everyone for attending today, this first of our meeting. Thank you for your very thoughtful and positive contributions. Richard will be chairing next time round, and I look forward to seeing you for that meeting. Goodbye for now.